Hi, everyone. Thank you for joining us today. My name is Miriam Goldstein. I'm Director of Policy at HFA, and welcome to today's session. This was originally scheduled for April 2020 at an in-person meeting in Baltimore and symposium. And like so much else this year, we have had to change and kind of change things up on the fly. So we're really pleased that you could join us today and really pleased that our speaker, Dr. Joey Mattingly, could still join us. I'll introduce Joey in just a minute, but I wanted to say a few words about today's session. So in bleeding disorders, we know that our treatments are effective, but they are extremely expensive. And we're fortunate to have a variety of treatment options with still more coming along in the pipeline, treatments with novel mechanisms of action and potentially gene therapies in the near future. There is no one-size-fits-all treatment for bleeding disorders, though. So making sure that patients have access to the treatments that are prescribed by their doctors, the ones that will best serve their health needs, is a really important task to us as we seek to be effective advocates. And that's where health economics or value assessment comes in. Evaluating the effectiveness of competing products in the context of their costs is a key part of how payers make their decisions to cover or not cover different treatments. And to some people like me, without an economics background, the topic of health economics can, and even the vocabulary, can be daunting or mystifying. Dr. Joey Mattingly, however, is an expert in it, and he's highly adept at explaining this material to a lay audience, to people like me. Dr. Mattingly currently serves as an associate professor and vice chair of academic affairs in the Department of Pharmaceutical Health Services Research at the University of Maryland School of Pharmacy. He teaches business strategy to Doctor of Pharmacy students, comparative effectiveness research in the PhD program, and is a strategic consultant for the University of Maryland Medical Center. In addition to his work as a faculty member, he's currently the Speaker of the House and trustee for the American Pharmacists Association. So one last word before I turn things over to Joey. I know he's budgeted time for your questions, so please type them into the question or the chat as we go along, or I think we'll be able to unmute at the end and ask in person your preference. So with that, welcome and thank you very much, Joey. I'm going to turn it over to you.
Fantastic. Thank you very much. And again, thanks to HFA for having me. I really do look forward to opportunities to speaking about health economics. So I'm actually a pharmacist by training initially, and went back to school to work on health economics. And so it was a great journey for me, and I love taking these opportunities today to share, even if it's just a small piece of it. And not that I expect anybody else to go and pursue a PhD after this lecture, but maybe you'll learn a few things and be interested and see some of the value that I find in it. Again, I work at the University of Maryland School of Pharmacy, as you said, and a couple conflicts in terms of, I just want to make sure I disclose. I do receive grant funding and consulting fees from a few organizations such as PhRMA, Massachusetts Health Policy Commission, National Health Council, and Bristol Myers Squibb over the last 2 or 3 years that all are unrelated to this presentation. But I think it's important to share that information as we are talking about a topic that's relevant to some of those funding sources. So what we hope to accomplish today, and again, it's about 1:05 Eastern time, and we're going to go to about 1:55. So over the next 50 minutes, I sure don't want to just lecture to you all the whole time. That wouldn't be a whole lot of fun. So hopefully, what we'll do is I'll target about 25 to 30 minutes of a formal presentation to cover a lot of the key topics that I kind of have on the screen here. We'll talk about defining some terms, making sure we're all speaking the same language, and then really hope to open it up, looking at the chat box to see what questions you have. But then if we have some time to even unmute and allow folks to ask questions as well. I really hope this is engaging. And again, I don't think we'll answer all the questions today, but in a way, like, can we at least get the conversation going and help you, get to the answers that you, for the questions that you have. So we'll cover all of these in a lot of detail, but again, we're going to talk about the difference between efficacy and effectiveness, and that key distinction between that, and then how that translates into cost effectiveness or comparative effectiveness. When we get into items like cost can be quite, it's not as simple as just saying, oh, well, it costs this or costs that. It's what type of cost. And so we get into direct and indirect costs and other types of costs that we are impacted by. And then we'll talk about the quality adjusted life year. It's one measure of effectiveness, or one of the preferred measures of effectiveness when health economists do cost effectiveness studies. And so you'll probably hear that a lot if you're engaged in value assessment frameworks or health technology assessment frameworks. And so I just want to make sure everyone kind of understands where that comes from. And then the term perspective is a really important term in health economics. We talk a lot about, whose perspective we're taking when we do an analysis. So first, we'll talk about efficacy. When you hear the term efficacy, this should really be focused, or this is really focused on whether or not a treatment is doing what we think it's supposed to be doing. So the gold standard are randomized controlled trials, right? And under ideal conditions, right? So when we're studying trials in the phase 3 clinical studies for drug approval or whatnot, we want to do these randomized controlled trials to really understand if this drug versus placebo is actually having the effect. And we don't want anything else to really mess with our determination. Is the drug working? So that's a really important thing for us to understand. It's necessary for FDA approval. It's helpful for us to understand, again, we were trying to make a decision whether or not the drug actually works. With that said, because it's under these ideal conditions, it's not always perfect for decision makers, right? So when you get beyond the clinical trial and you're no longer, now your patients are paying for it, or they have out-of-pocket copays, and so maybe you see adherence change, or there's just a lot of a variety of factors that might happen beyond the clinical trial. And that's where we get into the term effectiveness. Okay, so effectiveness is where you take it's really looking at, does the drug work in a real world setting compared to like when we talk about efficacy. So and also when we talk about effectiveness, and what we'll get into is comparative effectiveness, is not just is the drug working, but how does it compare beyond placebo? How does it compare against other standards of care? How does it compare against other reasonable treatments? This is what we need to make formulary decisions. This is also what we need to, having conversations around cost or whatnot, and because when we go to think about the actual decision that a patient's making, they're not making it in this vacuum that you might think of in a clinical trial that's got this strict protocol. They've got a lot of different options. And so anyway, this graph is just kind of showing that one particular type of comparative effectiveness or cost utility analysis is an example of or cost effectiveness analysis is this type of evidence is growing substantially, where we're comparing treatments, and that effectiveness term is what we're trying to really get at, not just taking it from the efficacy data that we have from clinical trials. And so when we get into these studies, we want to look at effectiveness, not efficacy. So comparing the terms again, real simple, just thinking about controlled setting for efficacy versus more real world setting for effectiveness. Think about efficacy being really important for the Food and Drug Administration and making that final approval determination. And then thinking about effectiveness being more impactful for payers, right? So just because the FDA approves it doesn't mean that once you put it in the real world and then compare it against other treatments, it's the most appropriate for the disease. And so that's why you see effectiveness, comparative effectiveness, being a little bit more important than, say, just straight efficacy. So you'll hear terms like burden or burden of illness in health economics used quite a bit. And what that's really getting at is, how much does getting sick really cost? What is the overall burden on the individual? What is the burden to the insurance company? What is the burden on society? And there's very different types of methods that can be used to answer some of these questions. And I just gave a couple examples, like if I wanted to understand the total cost of hemophilia in the United States, I could, what if I, from as a researcher perspective, what if I were to go into a claims database, identify everyone with the particular ICD-9 or ICD-10 diagnosis code for the disease, and then just take all their costs and just add them up? Well, that actually is a method that can be done. But the challenge is that gives us all, like, if a patient with hemophilia also has you know, 3 or 4 other diseases that are quite costly, just summing all of those things up may not tell us what is the cost that's attributable to hemophilia. So when we do our analyses and cost analyses, sometimes it's good to know everything, right? So that's not a bad thing to know everything. But when we want to then say, well, the cost of hemophilia is X, then you have to make more of you have to dive in a little bit deeper and maybe use different methods where maybe we put, you know, hemophilia patients in one group, and then we match them with another group of patients that have all the, you know, very similar characteristics other than the hemophilia diagnosis, which is tough to do, but there are methods to do that. And sometimes you need a pretty large population to do those kind of matching methods. But anyway, so there's statistical methods and other research methods that we do to try to estimate when we want to see, like, what is the cost of a very specific disease state, right? Because often our costs are a combination of things. You know, it's not just the one disease that's the cost. Maybe it's a combination of, maybe we're diabetic and we have, you know, multiple things going on with us. And then to go even further, so that's just saying if we were just to take any one cost, right, drug costs or whatever. But you have to really define, like, what are the costs that you're looking at? Typically, for about 80% of the cost effectiveness analyses that have been published over the last 20 or 30 years are focusing primarily on what I'm showing on the screen now, are direct costs, meaning, you know, what are the costs of the drugs being used? What are the costs of the clinic visits? What are the costs of going to see the doctor? What are the costs of laboratory tests? And often we'll look at the current costs as well as future costs that we anticipate. But what you can probably imagine that could be a challenge is that, what about all the other costs? What about so beyond what we spend at the clinic or at the hospital, patients to go to the hospital can't be at work, right? Like a lot of patients may be missing work. You may also, we miss out on consumption of other goods, like you're not out traveling, helping the economy in other ways. Another area that I've been really fascinated with, just because, you know, I think we all probably experienced this at some point, is that maybe the cost isn't necessarily all on the patient, but then there may be a caregiver or a family member involved that also experiences cost because of the sick patient. And so how much of an impact does illness have on all those around us? I think there's a lot of work that can be done in that space, and would love to see our healthcare system do a lot more for caregivers, because I think, you know, empowering and helping our caregivers can maybe improve the experience a lot of patients have. But that's for a whole other topic. We can, Miriam, we can schedule a caregiver focused discussion down the road if HFA wants. But anyway, when we talk about a lot of health economic studies, very few, so about 1 in 5 studies dive into these indirect costs, which is something that I hope changes over time. I hope we start doing more in this space. I guess for this, one thing for you all maybe to consider, I don't know how familiar you are with the Patient-Centered Outcomes Research Institute, or PCORI. But PCORI, during the reauthorization in 2000, or this past year, 2019, it was reauthorized for another 10 years. And they added some new charges where PCORI can now do a little bit more in the cost space. And they're going to put a lot more focus on things like caregiver burden and indirect cost, productivity, missed work, things like that. So I'm hopefully PCORI will be another organization that will start helping us estimate some of these things. All right, so let's see, do a little time check. So 1:15, I think we're still doing pretty good. And also, if you want, you can go ahead and as you're thinking about questions, you're more than welcome to type into the chat box. You know, and like I said, if I can address the questions as we go, or at the end, that's fine. Again, we'll do more of a Q&A, formal Q&A at the end. But if you have a question as you're thinking about it, you just want to go ahead and write it down, that's fine too. So let's talk about this quality, the quality adjusted life year. Oh, I apologize. I put in one of the bullets that we'd be doing this in a separate module. This is just for this particular topic. What we're going to kind of talk or want to touch on with the quality is basically I want to discuss that it's a way to take the quality of life and to incorporate that into our health economics assessment in some way, shape, or form. Because sometimes I think we hear folks that want to advocate that for different reasons, there's different challenges with the quality. But without the quality adjusted life year, if we only used life years, okay, if we only focused on mortality, then in a way we're not doing a fair assessment of what's happening from a quality of on the quality of life. Like without looking at morbidity, so quality of life, things like palliative care would have no value, right? Like if you're not extending length of life, then something without something like palliative care would not be valuable. But we know that's not the case. We know that in a lot of cases palliative care is worth paying for. Palliative care can be good. Or if you if you fall and break a bone, you may want a pain medication, or you may want, and so pain medications just for even short-term things are valuable because it reduces pain and it will reduce our quality of life in the short term for an acute injury. So how do economists come up with ways to estimate this quality of life score, and then how do they adjust, basically adjust? So that's what the adjusted life year means, is then we say, okay, for for 1 year, if you had perfect health, then that would be the same as a 1, or you'd get 1 for that 1 year. But then anything less than perfect health, we would score that less than 1, and 0 being the lowest you could go. So 0 referring to death. And so this allows us to then estimate kind of in that space that, okay, if, say you have, and I keep using something like a broken bone just because I think it might be easier to think of, but like, say that there's a health state that's not perfect, less than perfect. So like an injury, and during the time while you're injured, you're thinking, gosh, if I could have a whole year of perfect health, like how do you compare those two? Say it was a 0.8 instead of a 1. What we're trying to do when we're comparing treatments is we want to choose the treatment that's going to get us the closest to the most number of qualities. And so that's why you'll see comparisons, and I'm going to show a comparison in just a second when we do like an incremental cost effectiveness ratio, is that you're trying to evaluate these treatments on which one's going to offer the most qualities for the least amount of dollars, if you will. And some of the challenges come into play is, I think where it gets debated is how do we get to the quality adjusted life year score? Like, how do we know what's a 0.8 versus a 1? Is it disadvantaged for the elderly? Is it disadvantaged for the disabled? Like, those are questions that often come up, and so probably needed for an entire, you could probably do an entire session just on the quality. But I think that's something that, like I said, if we have questions at the end, we can dive in a little deeper. But let me use it as an example and see if that helps maybe frame it up a little bit better. So when we do cost effectiveness, we try to take, we want to look at an incremental case. So we want to look at a new drug versus an old drug. So this isn't drug versus placebo, right? So we're thinking effectiveness, not efficacy. In our numerator, in this incremental cost effectiveness ratio, which is also the acronym ICER, which that's, if you all are thinking of ICER, the Institute for Clinical and Economics Review, they cleverly, came up with their acronym using a term that's used often in health economics. But the cost effectiveness ratio is simply what it states. It's a difference in cost divided by a difference in effects. So the typical result is like a dollar amount divided by quality. So you'll see for every quality gain, you know, did it cost an incremental, like did you spend $50,000 in addition to what the old drug costs for a gain of one quality, right? So then that would be 50,000 per quality. And so one of the things that comes up is that while the cost per quality is what's recommended in health economics and what you'll see most frequently, there are other ways to measure effectiveness, and you can do a cost per something else. You could say a cost per hospitalization avoided, cost per yeah, you know, there's just a lot of, sometimes you'll see just cost per life year where they don't do any quality adjustment. But remember, if you don't do a quality of life adjustment, it's only a mortality focus. So this ratio doesn't have to be cost per quality, but it's recommended as that's the preferred one. So let me take an example on, and so rather than a hemophilia, I think for us to just talk about, I like using a very simple statin example, statin versus the PCSK9 inhibitors for cholesterolemia. In this case, you know, the table that was presented in this cost effectiveness analysis, and this is looking at patients who either got the statin, so they got a statin, looks like, wait a second, it looks like we had a statin was the comparator, and then it was a statin plus Zetia or a statin plus PCSK9 inhibitor. So you had 3 different comparisons. And so that means at the base case, there were no placebos, right? So that the baseline, everybody gets a statin. So then we're just seeing what's the incremental benefit of adding the drug Zetia or adding the drugs, and I don't remember which PCSK9 inhibitor that was. So now you'll see across the table, we have things like person years of treatment. We have MACEs averted, so that major adverse cardiovascular event. We have qualities gained. So you see you're gaining qualities when, in this case, they estimated qualities that were being gained during the, you know, when you add both Zetia or the PCSK9. And then we do have an incremental cost in drugs and incremental other costs, but you essentially end up getting a cost per quality of, I guess in this case, you know, $74,000 per quality and $170,000 per, you know, for the PCSK9. Let me shift gears to show kind of, oh, sorry, this is that same slide. So it's important to show all these columns to understand, like, you know, don't just look at the ICER, look to see like what are what's the what are the breakouts of the ICER. And then also when you ask this, you say, well, this is a very specific number, right? 74,000 or 170,000 per quality or whatever. It's very specific. It's typically built off of a model, which has a lot of assumptions. And so what you should also be asking is, how do we handle in those assumptions things that we weren't totally sure about? What are some other things that, so when we made the assumptions for like costs of the drug, well, depending on the insurance company, different insurance companies negotiate different prices for drugs. We talk about cost of hospitalizations. There's a lot of variability in cost of hospitalizations. And we talk about quality adjusted life years. We talk about the quality of life differences in different disease states. There's a lot of uncertainty. So what you should also see is some type of range. So you should see that, but what they'll often call a base case, and that's like that one table. But then there should be like a little bit of a range that says, well, it could be as low as this or could be as high as this based on certain assumptions. And here, actually, one thing I want to do is, looks like I do have a question, see if I can answer right now. So Jane asked, how does evaluating indirect costs work when the patient population that may use a given drug ranges from pediatrics through adulthood? Oh, great comment. Impact on productivity sounds like a measure for adults, but impact on caregivers would be more significant for pediatrics. Fantastic question. And this is exactly why So what I actually might even mention in this case is, because I don't think I have a slide to really talk about this, is also what we refer to as heterogeneity, or just the differences across the population. So if the disease spans the entire like the lifespan, um, trying to produce, when you produce one number, so let me go back to that little number. So let's just say in this case, now this is a bad example for that. So, you know, for cholesterol, but this is presenting one number for an entire population. Now, can you imagine that if you have a disease that is very different for children than it may be for adults, or in the case of, yeah, like using productivity or what have you, it may be worth having if you have this number, that then you redo the analysis and what we call a sensitivity or scenario analysis, where we say, okay, we then further looked at just children, or we then further looked at just the oldest adults or retirees or whatever. Like there's different ways that we can do this, and that's what health economists can do. Then, and they shouldn't just stop at one number, because see, often like an insurance company or a decision maker just wants to say, okay, is it approved or is it not approved? But it's a lot more complicated than that, right? Like oftentimes we might say, okay, it looks like it's cost effective for the whole population, but when we break it down a little bit, it's less cost effective for children than it is for adults. So for children, we're going to require some additional prior authorization. We're going to require some additional information, which obviously we're not always the biggest fans of when we have to do additional hurdles. But the point is like you want to try to guide therapy in a way that's cost effective. To the point on indirect cost. So I'll tell you what, one of the things that's challenging is that right now we're barely doing this as it is. Like we're not even doing it at all. So I'm impressed whenever I see a health economist try to do anything with indirect costs, just because very few do. But when you go to do that, the data can be really poor. So meaning we'll have like a randomized controlled trial that says drug A is better than drug B. But when we go to do the productivity, maybe all we have is a survey, like one survey that doesn't have a comparison group. There's not really a lot of statistical analysis around it. It's just kind of a blanket survey. And from a method standpoint, you're like, well, that information is not as strong as a randomized controlled trial. Well, so that's where we get into when we make these assumptions. So going back to, like, again, thinking of what's happening with cost versus cost and effects versus effects. So walking through the scenario, let's assume, and let's again take this, a population's given drug ranges from pediatrics to adulthood. If we put all the costs for the whole population in drug A versus drug B, and all the effects of drug A versus drug B, we'll come up with a number, right? I mean, it's just math, you'll get a number. But what you should be asking is, well, what happens if we were to if we were to just do it for pediatrics? Would the cost of drug A look better than the cost of drug B? Like, what's different between the two? If say a new drug's coming out and it's going to allow, maybe it's going to, I'm trying to use an example, like let's say instead of it being like an injectable drug, which may be harder for children to give themselves or something, I don't know, and it was going to be a patch that would be very easy for them to just put on. That might be really beneficial. And again, we might say, well, that's beneficial for all of us, but probably even more beneficial for children than, say, for adults. Well, that would be one that we'd want to do a scenario analysis on and say, well, this new method of delivery could be really good for children. One thing I'm thinking of is the Dexcom, I think it's a Dexcom device, those continuous blood glucose monitors for diabetes. One of my best friends has a son with type 1 diabetes, and he's only like 3 years old, and I can't imagine that poor little guy having to get stuck multiple times a day, which they did when he was first diagnosed. But once he got the continuous blood glucose monitoring system, it allowed the parents a lot more flexibility and allowed them really. And so I can see certain devices, and you all are probably thinking too, in the different patients that you represent, there probably are advances in technology that might have a difference for children than they would for adults. And so that's the questions we got to ask. And I'm not because I'm not an expert across all these different diseases, what I tend to do is I work with patient organizations and patient groups to talk to you first and say, okay, what are the costs you experience? What are the costs that your patients are most likely to experience, and what are the effects of that? And most recent example was with the Asthma and Allergy Foundation of America, AFA. We did a study with food allergy patients, because food allergy patients primarily experience a lot of indirect costs, or costs related to their food bill, costs related to their lack of travel or challenges at work, or being able to go to restaurants, or things that were outside the healthcare system. And so without me talking with that patient advocacy group and actually working with patients in that space, it would be it'd be really difficult to really assess what are all the different types of costs. So great question. And again, always kind of remember that it's incremental. So we're doing A versus B. If the drugs are almost identical, or like they're the same delivery, there's not a lot of differences there, just a difference in effectiveness, then maybe it's not as important to split out adults versus kids. But so you just have to kind of walk through the scenario and ask, like, when would it be good to look at one or the other? So that's kind of what comparative effectiveness means, right? Like we're trying to take drug A versus drug B. Like we're not doing drug A versus placebo. We really want to see what are the risks and benefits of the alternative treatments. We want to be able to inform patients, but also clinicians, payers, and policymakers. And so with that, like, you're thinking of, whose point of view are we asking the question? Oh, let me look at the time, 1:30. So we need to make sure we get into Q&A soon. But with that, like, if we're comparing these things, what are the differences? Like, if you're a patient, you're going to have a different perspective on what you experience cost-wise than, say, an insurance. And insurance doesn't care what you spend on groceries in a way. And again, no offense to insurers, it's just that if they're not paying for your grocery bill, then they don't care if you have to spend more on groceries, or whatever that might be. Now, they may care about productivity. The payer initially may not, but the people they represent, like the employer groups care about productivity. So depending on who you're looking at. And then from a society perspective, you also have to consider what we think of as opportunity costs. So if we spend money on this particular new treatment, are there other things that we won't have the budget for? Or do we need to increase premiums or whatnot to cover all these new costs? So thinking about what the perspective is, and so when you think about perspective differences, and you'll see this with an ICER report, they'll do a health sector perspective or a payer perspective, and they'll do a societal perspective that they'll often kind of put at the bottom. That's not like their main focus. Their main focus will be the payer perspective, and that's all the direct costs that I was talking about. And then they'll do maybe a modified, or they'll call like a limited societal perspective, which will have a few other things in there. And with that, I kind of want to, Miriam, I think this is where I'd like to kind of stop. I think another question in the chat box. I want to make sure we've got, so we're at 1:33. That gives us a good 15, 20 minutes solid for Q&A. Brenda asked that she's heard of some controversy using qualities in rare diseases. So to Brenda, it's not just rare diseases. So let me just say this. Let me put my, I thought I had my Q&A. Sorry, I thought I had my, I'll put my contact information on the screen. So I would say that it's not just the rare diseases that the quality is controversial. The quality adjusted life year is controversial for, I guess I don't know all the reasons why people are against it. I think I think there are challenges with it, right? So if, and I'll use an example. If we have to use a survey to estimate what the quality of life is for a disease state. So, and one famous example is an osteoporosis. There was a study where they asked women who had broken their wrists, who had fallen, broken their wrists, had osteoporosis, and had a break. If you ask women who have broken their wrist what the quality of life was during their experience with the broken wrist, compare that to women who also have osteoporosis but never broke a bone. Guess what? The people who actually have never broken the bone think the quality of life is way lower. meaning that we often overestimate the impact of something until we actually experience it, and we're like, wait, maybe it wasn't as bad as I thought. And again, that's not the same for everything. But doesn't that make a little bit of sense? Like, we always think that the grass is always greener, or that something's always going to be way worse than it actually is. And so the methodology can be difficult. Economists call this ex ante versus ex post, if you want that for trivia. But it's one of those things I like to think about. Is like, okay, how do we really find out what the true quality of life is for that health state? And then you have to ask, well, what does it matter if you overestimate or underestimate? If and I'll use I don't know, use a trying to think of a good example. I'm trying to think also with hemophilia, like what might be a good case example, and maybe that'd be one that we could walk through. And I could actually had the ICER report pulled up. It might even be something we could look at there. But one thing I would also add to that, Brenda, is that whenever you hear, like, it's important to go back and look and say, okay, who's challenging the quality? What are are there other things that are behind it? I shared with you my funding disclosures specifically because I want you to know that I get paid by organizations to do different types of research. I'm pretty stubborn, and I like to say what my opinions are, regardless of who's paying me. But with that said, it can have an influence, right? So pharmaceutical manufacturers are going to be biased to want the value of the new treatment to be worth more, so they can charge a higher price. That's their bias. Now, it's not a bad thing if they want to make more money. I mean, it can be depending on your perspective, but like, that's just their bias. Whereas someone who's representing a payer, an insurance company, wants the drug to be as low as possible and to restrict access. So that's their bias. And so I think it's important for me, I like to just put all the methods out there, and then you can argue about it after that. But sometimes it's important when you see the controversies that come up, take a look to see if they're adding like a very specific concern, or if it's just a blanket, oh, the quality's bad, boo quality. Like, if it's just the quality's bad and we hate it, and it's, and there's not really giving a strong argument to it, then you might ask, well, what do you have to gain by not doing the cost per quality? Like, what do you, so, and that's if I can be a little bit liberal with my conversation or my opinions there, that's sort of my opinion, is I would just dig a little deeper and say, well, what exactly is your problem with it? Oh, good. Yeah, thank you for opening audio. If anyone would like to raise a hand and share, and I can, like I said, I can try to read the question as well, but love to hear from you as well. How do patient advocacy groups impact, influence these decisions? Oh, I love this question. So this is what I was hoping we would get today. So I think, so this is where I think health economists are slowly but surely coming around on. Definitely not all health economists. Some health economists are of the opinion that talking to patient groups only biases your results. Like, say if I were to work with the Hemophilia Foundation and I really liked you guys and we had a great relationship, and you were like, oh, Joey, we really want these drugs to be approved. We want to make sure that we show they're cost effective, right? Like, you could see how there could be some bias interjected there. And so some health economists feel like we shouldn't work with patient advocacy groups because that may bias our results to showing it's more cost effective than it really is. Because maybe the decision is meant for the whole population. And that if we spend more on hemophilia, are we going to spend less on cancer or spend less on HIV meds or like other things like that with opportunity costs? I'm of the opinion that I am not smart enough to know all the things that patient groups go through, and that if I fail to account for all those things, I'm really not doing the math right. I can do the math, it's just not set up appropriately, right? Like, I didn't count everything. And a good example of that, trying to think of some example. Oh, so I've done some work in hepatitis C, was very recently, where we did what we called a patient-centered cost effectiveness analysis. We worked directly with hep C patients and found for a lot of patients that when you go into it, you think, oh, a patient's going to definitely want the drug. They're going to want to pay as much as they can for the drug and get all the benefits, whatever. That's not what patients told us. Patients would often tell us that their hepatitis C may be like the fourth or fifth problem on their list of things. Like it wasn't their biggest issue. Some patients didn't find value in treatment because if they were still using opioids, and heroin is a major a major challenge for some folks that have gotten that infectious disease, and so they need good drug treatment options for their opioid disorder before they can even think about curing the virus. And so we started learning a lot more richer information about the experience that patients have. And then we found out for a lot of those patients that the stigma that comes with having Hep C was really bad. So just having the virus in their bloodstream created a lot of other challenges for their life. And even if you cure the virus overnight, they're not getting rid of that stigma. There's still some of those things that they have to battle. And so I felt like we were able to do a better economic model because we gathered that information and thought about that. And so some health economists are going to disagree with me that I shouldn't go through that process. But for me, I feel like I learned a lot more about the full experience. It allowed me to then create, in our model, we did the cost per quality like a traditional economic model, but then we also did a cost per infected life year. So we could show patients for Hep C how many years they could get back where they have no infection. And so they could live a more normal life, right? So that they don't have to worry about infecting other people and things like that. And so that was just, our way of saying look, patients told us that they really just wanted to be able to say, I no longer have the virus. And so that's how we were responsive. So patient advocacy groups can certainly get involved by, by working, again, if you work with, if in a group like ICER, for example, I think that most of you are probably getting engaged with, the Institute for Clinical and Economic Review. They've just hired someone, I can't remember her full title, but that's going to be in charge of their patient engagement activities. The last 3 to 5 years or 2 to 3 years, they've done a lot more on the engagement side, and they're reaching out to groups to get groups involved earlier in the process, to give comments and feedback. And you don't have to be a health economist. I've had several patient groups that have asked me to help them with an ICER report or to give them some advice on some stuff because they don't have a health economist on staff or something like that. And as I've walked through some of the stuff with the groups, once we kind of get talking about it and they're like, oh, so you're just talking about productivity costs, you're just talking about missed work, because a lot of times these health economics reports are so complicated and convoluted that it's really not as complicated as we like to make it out to be. So maybe at first you just need to and that's what this type of presentation is about. I just want to share with you all some of the lingo so that you're not intimidated by it, so that you don't think, oh man, I'm just going to not read that because that's too much. So just kind of feel a little bit more empowered, ask questions. When you find out so one thing's the health, the ICER reports, they put in there who the modeling teams are, the health economics teams are. And so when they do have different calls, they may have opportunities to engage with the people that are building the model. And they're a lot like me. So they've got my similar training and are university professors, because ICER often doesn't do the report themselves. They contract out with groups like Colorado, University of Illinois, Chicago, which I think was on the hemophilia report, University of Washington, University of Maryland. They'll contract out with these different groups to do the reports. Let's see so Kim, I hope that answers in terms of how you can impact and influence. One thing too, so sometimes we don't have a lot of good information about a disease state or an area, and that's so recently that food allergy one that I mentioned briefly. There's very little information out there about certain quality of life scores for children with severe peanut and milk and egg allergy. So the AFA, the Asthma and Allergy Foundation, sent out a survey and got a really quick response from their members, and ICER incorporated it into their report. So Kenny Mendez, the CEO of AFA, is actually become more of an advocate, at least saying, look, if you're an advocacy organization, get involved early. ICER will listen. They won't just listen to they're less likely to be convinced if you're not able to bring a little bit more, if you can survey your members or bring some additional stuff to the table, that helps a little bit more than say just a policy or advocacy person giving kind of the political spiel. So if you can engage your members and hear directly from your members, and I don't know how engaged your community is online, like if they'll respond to emails or respond to surveys, those can be powerful.
Yeah, and if I can just interject, in the most recent ICER review, that actually came up. So it turns out there are not enough surveys or enough studies on patient important outcomes of interest. And when ICER did its first draft report, they were using some really old, 10-year-old study data on how prophylaxis is done with factor VIII. And the standard of care has frankly evolved since that study was published, and certainly since the study data was gathered. And so while we didn't have patient-generated surveys that we could provide them with, we did have through ATHEN, which is the Association of Thrombosis and Hemostasis Network, we had sort of some data that we could provide that attested to the actual standard of care, as currently practiced. And so that went into their final report, and we were glad to see that. But I'm sorry to interrupt.
Oh, no, that's great. I'm glad you mentioned that. And the evidence can be really bad in some of these cases, or just not available. Like there's just nothing. And so that's why some of the stuff I do early on is I don't even do a survey. I'll set up where we'll interview 20 patients and we'll do in-depth interviews, and we'll turn on the recording, we'll do the consent and everything. And we'll just let patients talk and tell us what what their experience is. And then we do qualitative pulling all together the different themes and things that come out. So there's ways to do kind of deeper dives into things that, especially when there's no information out there. Sometimes you got to start with the basics. And I love that. The challenge is how it takes a long time to get research funded, to get it executed, and to get it published. So if an ICER report is starting next year, what is the chance that you're going to get any research done in a 1-year period and get it out and published into the report? So the tough thing is that it's a longer cycle. But what we want to do is, so if you all work with pharmaceutical companies or with as you're advocating for different things, companies that are working on these clinical trials, they should be thinking about this, especially if they're already in phase 3 and looking to get an FDA approval. They need to be thinking about these things. They may be focusing on that efficacy thing that I mentioned. Like right now, they're so focused on efficacy, but they also have full teams that they're like their market access teams. Those folks know that, hey, we do need some real world. We need to be thinking about real world evidence too. One question I want to make sure I answer Jane's comment on so ICER typically does the newly approved or soon to be approved reports for those new drugs. What about going back to previously done reports? Because ICER's been around for several years now. This is something that I've actually you're teeing me up really well, Jane. I did a study recently in 2000, actually early beginning of this year, where I basically called out what's the point of publishing a cost effectiveness analysis in 2020 if there's a lot of changes happening in a disease state, so that 2 years later, the number that I threw out there is no longer relevant. And the case that I used hepatitis C again, because that's the area that I've been spending a lot of time in. And in Hep C, from 2010 to 2018, a lot happened. There was like 10 or 12 brand new drugs. They went from 40% effectiveness to curing the disease at like 95% rate. The drugs went from like 40,000 to 90 to 100,000, all the way back down to 30,000. So, I mean, the costs were doing this, the effectiveness was doing this, all in like a 6-year span. Well, I can publish a model and put a model out there in 2012, and I can put it in a journal. And as an academic, like I put that on my CV and I move on, right? I publish my paper and I'm done. but that's not really helpful from a decision-making standpoint. Like as the inputs, as the costs change and as the effectiveness changes, a lot happens to that cost effectiveness ratio. And so that's what I actually wrote. I'm happy to share that if others are interested in that type of paper. But like I just showed 2010, 12, 14, 16, 18 in the Hep C case and showed what happens to that ICER over time. The problem is it's not cheap to redo these analysis every year or every 2 years or whenever it is. And so ICER, like any other organizations, you know, I think it's a 501c3, or I don't know if it's a C3. I think it's a nonprofit, but they get funding, I think, from various sources. Arnold Foundation, I think they get some funding from pharmaceutical companies now too. I don't know. They get different various donations, but they have operational cost, and they contract out with universities to do these models, and they can be kind of expensive to do. So they'll publish the model, and then they're not really going to change it unless something super big changes, or they get funding to do it. So I think that's a big challenge, Jane. I think that's a great question. So what I would do is, if there is a situation where you know that the evidence is really has changed, you might advocate for that. You might request or send something, say, hey, is there a plan to put this on the, because I think they announce every year, they'll say, here are the 20 areas we're going to explore over the next year. I think they do some type of announcement like that every year. But like with that said, they only have so much budget to evaluate and do all these things. That's a real problem. I think that's a real problem for this whole industry, is like, I say industry, like my profession, is that how much of it is academic, like an academic exercise, and how much of it is like really helpful. And so we are seeing some people doing like a model that's totally transparent. Like I did a model in penicillin skin testing for penicillin allergy, and I did it all in Microsoft Excel, and we put it on in +1 and made it publicly available, so someone could just download that. And if you had, again, you still have to know how to use the Excel and use like, it's probably not, I don't know if anybody could just pull it off the thing and just start messing with it, but some groups are making their models more publicly accessible. Some are creating things online where you could just go to a website and change the model and change the inputs. But everything I've seen, you typically still need a little bit of training before you can just go in and start changing numbers. But great comment.
With this new focus that you said PCORI can kind of expand its mission a little bit, that might be a great place for PCORI to step in and do the follow-on studies. I don't know if that's a possibility or not.
So I think they are very aware of that. I think they know that cost effectiveness can't do. Nothing related to cost effectiveness, nothing related to the quality adjusted life here. So they stay away from those things. But costs are now going to, so a year ago, so I went through the process of getting a PCORI award last year or 2 years ago, where I had a program officer tell me, don't even look at cost as like a secondary outcome. They don't want you to look at cost, just the other outcomes. And I was like, well, patients care about cost. Like patients bear the brunt of it, But they were very nervous. Like they just weren't into. It was something politically part of their, I guess, part of their initial 10 years of funding. But now they do feel emboldened. They do feel that, okay, now we can start looking at this. And so I do think over the next few years, we're going to see more research funding available for this. Just know that that's a 2, 3, 4 year process. It takes a year to get the grant funded, 3 years to get the grant completed. And so that's why it's probably got to be a combination of things. But I think for groups like HFA, like, if you have the bandwidth to explore doing a Eugene Washington Engagement Award through PCORI, they have mechanisms where you can maybe do different things to form, to build an engagement plan. There are ways to then do comparative effectiveness research, or to work with other researchers that are in this space and collaborate with researchers on this using PCORI as the mechanism of funding. I try, whenever I do a PCORI proposal, I always ask which advocacy groups are open in that space that are willing to participate in that kind of stuff. So my Hep C work that was funded by PCORI, I had the American Liver Foundation as a partner.
Yeah, and HFA does in fact engage with PCORI, but not in this area. So our research team does some work about involving women in patient-centered research.
Oh, cool.
But yeah, well, if I can take the prerogative of asking one last question, I think we're getting close to the end here. But you talked about some of the uncertainties and how health economists deal with that. And so I wanted to come back to that area, because we are apparently very close to getting the first gene therapies approved in hemophilia.
Yep.
And obviously those are intended to be lifelong treatments, but they will of necessity be approved on a short lifelong record. And so how does a health economist factor in that uncertainty? In addition to the idea, and I guess this would have been true of the hepatitis C therapies, you studied something that's curative, comparing something that's curative to something that is a maintenance therapy.
Yeah. Yeah. So what typically happens with uncertain when we think about sensitivity analysis or different scenario analysis. So we like to do what we first call is this kind of base case, maybe a more simplified, like, here's just what we think, and we think this is going to look like, right? And here we get an answer. And so the answer is $50,000 per quality or whatever the final result is. When we start our sensitivity analysis, we start changing in one simple way. They call it a one-way sensitivity analysis, is that we take one variable. We don't change all the variables. We just take one variable, and we maybe take it from its, whatever its average to like a low or a high. We just start moving that one variable around. When you move the one variable around, what happens to the 50,000? Does it go to 55,000? Does it go to 45,000? Or does it go to 500,000? Like, how impactful is that one variable? And so what you'll often see is when we do this one-way sensitivity analysis is that a lot of researchers will present it in a picture that looks like a tornado. It's called a tornado diagram. And it's like that because it puts the variables with the biggest swings, they're at the top. And so the ones I was talking about with hepatitis C, my productivity assumption. So my productivity assumption had a wide range. It went from like $0 to $13,000, $14,000 a year per patient. Because of that wide range and that assumption, that was one of the bigger variables that like had a big swing. Whereas other things like the quality of life in liver transplant patients, while is very important, because a very small number of patients ever go to a liver transplant, it actually wasn't a big variable in the model, because no matter if I changed it from 0.2 to 0.8, the model didn't move a whole lot because very few patients. So the point being is you do these sensitivity analyses across the variables to say, okay, which variable is like the biggest one that's going to give us some problems. And then we say, okay, this one's causing a lot of problems. What are not problems? This one has it's sensitive to that variable. So what can we do to make sure the evidence that we have is really good? And if the evidence isn't good, then I think you have to put the caveat there. The problem is, I think a lot of economists, a lot of researchers, we don't like to talk about our limitations, so like our limitations get really confusing. And so we like to stick them at the very end of the paper. Oh, we did all this fancy stuff. Here's our result. But then, here's like a paragraph of limitations that we just want you to be okay with. Well, sometimes that's the devil's in those details. So I think it's important that if the assumption is, we see this, it may be a lifetime model, but we're making an assumption that someone's going to live 20 years versus 10 years. You start playing with that one variable, and then you see, does the $50,000 per quality go from 50 to 55, which you might be okay with. But if it goes from 55 to 500, you're like, okay, that's a big swing.
Thank you.
All right.
Well, thank you so much. I think, let's see. Oh, the chat is a reminder about this. So this is for Joey. This is HFA's Week of Advocacy, another event that had to go virtual. And so we are going to having a reception online is kind of different than having it in person where we can actually feed and give people drinks, but we are having a congressional reception and 2 congressmen are going to talk to us tonight at 6 p.m. So anyone who is on the call, we would love for you to join us. But thank you so much, Joey. This has been really helpful. Just sheds a lot of light on what can be a very confusing area. And we are very grateful for your work with the National Health Council, to which we belong, and for coming to speak with us today. Thank you so much.
Great. Thank you all.
Thanks, everyone. See you soon.